Welcome to The Explainer. Today, we're diving into something truly daunting, a rare but incredibly deadly condition that is one of the biggest challenges a surgeon can face.
So let's just jump right in with a question that's simple, but honestly, it's pretty terrifying. What happens when one of your body's major pipelines, an artery, gets infected?
Well, the result is what you see here, an infected arterial aneurysm. And this is just as bad as it sounds. We're talking about an infection that attacks and weakens the wall of an artery, causing it to bulge out like a balloon. It basically becomes a ticking time bomb, threatening a catastrophic rupture inside your body.
So you might be wondering, how does something as strong and vital as an artery even get infected? I mean, it's a fortress, right? Well, it turns out there are four main paths to this kind of disaster. Okay, path number one is what we call microbial arteritis. Just imagine bacteria floating around in your bloodstream, maybe from an infection somewhere else entirely. They're just looking for a place to land, and if they find even a tiny weak spot on an artery wall, that's it. They set up camp and start attacking. Second, we have what's called a post-traumatic pseudoaneurysm. This is all about direct contamination. Think about trauma, sometimes linked to things like illicit drug use or maybe even a medical procedure that went wrong. Bacteria get introduced from the outside world straight into that artery. It's a direct invasion.
Now the third way is, well, it's kind of sneaky. Imagine someone already has a regular, non-infected aneurysm. It's there, but it's stable. Then bacteria get into their bloodstream for some other reason. That existing aneurysm, it's like a perfect, pre-made home for those bacteria to latch onto, and in fact, all of a sudden, a long-term, manageable problem becomes a life-threatening emergency.
And finally, the fourth path, which was actually first described way back in 1885 by the legendary Dr. Osler. This involves something called septic emboli. Picture this. You've got an infection on, say, a heart valve. Little infected clots can break off, travel through the bloodstream like little torpedoes, and then lodge in a distant artery, starting a whole new infection there.
So let's put it all together. What's really interesting when you look at this chart is how different causes tend to target different parts of the body. For example, a post-traumatic infection often happens in the femoral artery in the leg, right? That makes sense. But an infection coming from the heart, man, those septic emboli can go anywhere, seeding disaster all over the body.
All right, so we know how it happens. But who are the actual microscopic killers behind these infections? Let's take a look at the bacterial rogues gallery.
Okay, so a lot of different bacteria can cause this, but really, two big names dominate the scene. First up is Staphylococcus or Staph. It's responsible for a huge chunk of cases, up to 71%. And yep, that includes the nasty resistant kind. Then you've got Salmonella. Yes, the same bug you worry about with undercooked chicken. It's a major player here too. But, and this is absolutely crucial, not all bacteria are created equal. You have gram-positive bacteria and gram-negative bacteria. Now, while gram-positive infections are more common, the gram-negative ones, they are just devastatingly more lethal. I mean, look at these numbers. An 84% chance of the aneurysm rupturing, an 84% chance of the patient dying. That is just a terrifying statistic. And within this gallery, you've got some real A-list villains. Of course, there's MRSA, the superbug that's so hard to kill. Then you've got Salmonella, which for some reason just loves to attack the aorta, the biggest artery in your body. And then there's this one, Clostridium septicum. This one is a nightmare. It causes an incredibly fast, aggressive infection, and get this, it's often a sign that there's an undiagnosed cancer somewhere. Okay, so with stakes this high, how on earth do doctors find these things before it's too late? It is an absolute race against the clock. You know, one of the biggest problems is how vague the symptoms are. We're talking fever, chills, maybe some back or belly pain, stuff that could be anything, right? Sometimes, if you're lucky, there's a new, tender, pulsating lump a doctor can feel. But a lot of the time, the clues are so subtle, which makes diagnosing this a huge challenge. So that's why this is the key takeaway. You absolutely need advanced imaging. A computed tomography angiography, or CTA, is the gold standard here. It's what lets doctors actually see the aneurysm, its shape, its size, and all the inflammation around it. It's the only way to really know what you're dealing with. All right, take a look at this scan. This is from a real case of a Clostridium septicum infection in the thoracic aorta. See that? The wall of the artery is thickened, there's some gas around it. It's definitely dangerous, but at this point it looks, maybe, contained.
But remember what I said about Clostridium septicum? This infection moves at a terrifying speed.
10 days. That's all it takes.
And look at it now. 10 days later, the aneurysm has exploded in size. This is a full-blown surgical emergency. It just goes to show you the incredible race against time these surgeons are facing. This isn't just a problem anymore. It's a catastrophe waiting to happen.
So, once it's diagnosed, it's go time. Surgeons have to perform what is honestly one of the most challenging operations out there. The goal isn't just to patch a leak. No, they have to go in, cut out the entire infected part of the artery, and then somehow rebuild that critical lifeline.
And the game plan for this kind of surgery follows 5 key principles. 1, you've got to get control of the artery, stop the bleeding. 2, take samples so you know exactly which bacteria you're fighting. 3, and this is probably the most important step, debride. That means you have to cut away all the infected, dead tissue. No half measures. 4, rebuild the artery with a new pipe. And 5, you cover that new graft with healthy tissue to give it the best chance of survival. But here's the million-dollar question. What do you use to rebuild it? Remember, you're putting a brand new part into an area that's full of infection. The choices are pretty incredible. You could use an actual artery from a deceased human donor. You could use a standard synthetic graft that's been soaked in powerful antibiotics. Or, and this is amazing, you can do a procedure called a NACE, where the surgeon literally builds a new aorta for the patient using veins from their own legs.
And this is where it gets really tough for the surgeon, because there's no perfect answer. On one hand, you have these allografts, the donor arteries. They're fantastic at resisting reinfection, but they're hard to get and they're expensive. On the other hand, you have the antibiotic-soaked synthetic grafts. They're readily available, which is great in an emergency, but there's a higher chance the infection could come back. It's a massive life-or-death decision that has to be made right there on the spot.
Which brings us to a pretty sobering final thought. What surgeons can do for these patients is nothing short of a miracle. But we have to remember, we are in an arms race with an enemy that is constantly evolving. With antibiotic resistance on the rise all over the world, you have to ask, are these incredible surgical skills going to be enough to keep winning the fight against an enemy that, while microscopic, is one of the deadliest we face?